May I request Dr. G. Srikanth to talk on surgery for median arcuate ligament.
Good afternoon, chairpersons, senior colleagues, and friends. This is an operative video on release of median arcuate ligament in a young lady who presented with recurrent pain abdomen over 6 months duration, a little over 6 months duration, extensively evaluated, seen by a couple of medical gastroenterologists, and then referred for a decompression of the celiac artery. Now the CT, the sagittal image shows the compression by this connective tissue band which goes across the aorta, which is variable in position, and there are many patients who may have this finding who have no symptoms. So patients who have pain too, since this finding is found in normal patients, which means roughly about 5% of CT abdomen, so it's pretty common. So you can't jump at this, but when you have a diagnosis established, others ruled out, and you have a discussion with your medical colleagues and then come to a conclusion, celiac artery decompression can be done, which was originally described as an open procedure, but more often now is being done by the minimally invasive approach. Now, when you, the position of the patient, procedure done under general anesthesia, leg split, you have a foregut port position, which is a camera in the supraumbilical location, a left and a right in the mid-clavicular. This is an instrument from the epigastric port for liver retraction. Now, the first step would be to divide the hepatogastric ligament. This is a lean patient, so you could see the left gastric artery and the coronary vein through the hepatogastric here. Now the location of the celiac can be traced by tracing the left gastric artery down to the aorta. Now the anatomy is variable. There are patients where you could incise the peritoneum or the right crus and develop the retro-GE junction plane and then expose the aorta and work towards the celiac down. So here what you see is the peritoneum or the right crus which has been divided. You're behind the GE junction here. The left gastric artery is being retracted with the instrument caudally. And you don't do an extensive exposure here excepting the crural decussation. Here, you divide the crural decussation fibers to expose the aorta, typically for 3 to 4 centimeters. Now, this division can be done using a bipolar in the left hand and a hook cautery in the right hand. The hook cautery, that's the aorta exposed after dividing the crural fiber. So you have the exposure, now you expose it for a length of about 3 to 4 centimeters, coming to the celiac region. Now, with an open procedure, you would have the assistant who can give a caudal traction on the antrum of stomach and the coronary and the left gastric vessels to expose the celiac region. But when you do it laparoscopic, you could dissect off the left gastric artery, use a soft sling, and this soft sling gives a caudal traction, and you have the aorta exposed above, and so you go ahead and divide the connective tissue. Now the description is decompression in median arcuate ligament is, it should include a neurolysis of the celiac plexus. You have certain element of nerves entrapped within this connective tissue band. Now, the results typically indicate that when a median arcuate ligament is completely divided, you have a pain relief in the carefully chosen patients in 80%, which means 20% still could have pain. So choice of patients critical, having a careful discussion, ruling out other causes before you take up. Now, with the caudal traction on the left gastric, you work and release. So you have certain crural fibers from above, but then you have this connective tissue band, which you progressively release. You can see the dilated part of the celiac artery beyond the area of compression. You have the aorta celiac. So it looks that the procedure is complete, but one has to be careful, have this caudal traction in place, and this last part perhaps is best done using a monopolar hook cautery and not with a harmonic shears. Now you see the monopolar hook cautery releasing. This release of median arcuate, if you have chosen to do this procedure, it has to be complete till you see the aortic, the celiac take off clearly from the aorta. So here you see it's almost cleared, the aorta, the celiac artery, common hepatic, and the left gastric artery. And you clear 180 degrees on the superior side, basically to achieve complete release and also neurolysis, which is a part of the procedure. The monopolar cautery, when used in these situations, when you're working around vessels, it best works if you use a 20 setting in a valley lab, or if you're using a 4-strad platform, a 25 setting. And the use of the energy when you use near vessels should typically be for a 2-second to 3-second burst. Now, in doing the mobilization to expose the aorta for that 3 to 4 centimeters to have a clear vision, one should not go overboard and do a lot of mobilization of G junction area. You just need to get the G junction off and then divide the crural decussation area, the left crus fibers basically, to expose this. The position of the celiac artery takeoff is variable. So one needs to have a careful study on the preoperative imaging. So that's, we have come to the end of the procedure. Clearly you could see that the ligament is completely released. You could see the origin of celiac taking off from the aorta. Use of higher energy, use of longer use of monopolar could have effects such or complications such as a bleed from either the celiac artery or from the coronary vessels. Typically, these patients are, the post-operatively are started orally 4 hours after the procedure and discharged. These are rare referrals to us. In the last 20 years, we've seen 4 patients. There was one other patient we didn't operate. These patients, 50% in one recent large series, 27. Others are case reports, had shown visceral artery aneurysms can be there in 45% of patients. So rupture of these aneurysms seems to be higher in these patients, which are dealt with by intervention radiology. Thank you.
Yes, if I could put a question, do you think just dissecting the connecting tissue over the arcuate ligament is sufficient, or endovascular procedures, supplemental procedures are required to achieve complete relief of symptoms?
Yeah. There are reports of endovascular procedures. These are case reports, basically exercised in post-surgical patients in the immediate post-op when they have had complications, like post-Whipple procedure, where patients had pain abdomen, liver, LFT is deranged, and when they evaluated, they found that there was a stenosis. And these must have been evaluated pre-op, but these patients have been dealt with interventionally. But if you see, this is a connective tissue band which is tough, and it's an extrinsic compression, and the procedure described is celiac artery decompression. So endovascular cannot achieve much relief in obstruction which is extraluminal. So this can be used perhaps in selected patients. Now in a high-risk patient, if one has to do an angiogram, like you do in any vascular occlusion angiogram, and you want to attempt a balloon, careful ballooning, the intervention radiologist could do that. But you cannot balloon these obstructions. So I think the role would be limited. Maybe selected patients, it might be considered.
So you did a preoperative CTPA, triphasic CT of the abdomen. There was no stenosis. So this was a 20-year-old girl.
There was a stenosis.
Yeah, there was a stenosis. Okay, and just the extrinsic release of the compression was sufficient to achieve a complete resolution of symptoms.
Correct.
So you think this patient is not going to need anything further,
Now, yeah, so since you asked this, patients who have had a surgical, what looks like a satisfactory release of the median arcuate ligament, if they have symptoms, if they need evaluation during follow-up, and there you find maybe an endoluminal procedure, but this discussion becomes hypothetical, but I think there it could attempt, because you release the ligament anyway.
Srikanth, that was
is there a role for a stent insertion? Because
I think it might have.
That we have done.
It might have a role.
Following the release of the band to put a stent, because the fibrosis oftentimes involves the vessel wall, and the release of the connective tissue does not necessarily get rid of the fibrotic band in the vessel wall. I think that was a sort of question.
I think if the initial part of the video, when we were using the harmonic shears, it looked like the release was complete. Most of the time, one has to make a good attempt at release. It has to be clear. And if there is a recurrence, I'm sure there is a role for intervention radio, because there's nothing surgical you would do there.
yeah, Srikanth, I enjoyed your video.
Yes, please,
Yeah.
go ahead.
Dr. Srikanth, when you will like to reevaluate these patients? Because dilatation won't occur maybe on the operation table or immediately. So I think you have to do something evaluation at about 3 months.
Now, since this is a
For that-
rarity, there is no strict recommendation.
Yeah,
but
I
I
know-
think it
I
would
know
be
this.
reasonable to do a
Yeah.
Doppler in the on table. You could do a Doppler, but at maybe a week's follow-up and then maybe 3 monthly in the first year. Symptoms, I mean, patients would be asymptomatic.
Yeah,
Most of them.
and one thing is when the artery is very narrowed, I think sometimes it is a atretic kind of a segment. Don't directly handle this artery, because sometimes in open surgery one can hold it with a vascular forceps. In one patient we had a bleed and we had to take a few Prolene stitches. So after that we have taken a policy not to handle the artery directly with any instrument other than a sling.
I think peri-arterial tissue is what you would be holding.
Yeah, so what I want to say is also it takes a time for it to dilate. It's like a maybe small for age kind of a growth or artery, and now you want it to be normal
if
diameter.
you can cut short your questions. Yeah, please.
So we do evaluation at the end of 3 months. Okay.
Srikanth, can I get a question in, please?
Yes, please.
Yeah, please.
Go
Thank
ahead.
you very much. Our unit's preference is to go from the hepatic artery upwards. And advantage, at least perceived advantage to us, is that we are not coming blindly back down. But we are just sort of, we don't have to touch the hepatic artery. We go superior to the hepatic artery and dissect, lay open, dissect, lay open. And then you reach the celiac as well as the, in difficult cases, then you have to do a little bit above and then come back. Then you have a little bridge that you have to deal with like you showed us. So what are your thoughts about going below upwards?
I think it makes sense. Basically, trace one artery which is in line. In this seemed to be the vessel which we could give a caudal traction. And this is a described technique previously for left gastric artery giving a caudal traction. Perhaps that would be difficult with the right, but if you have the common hepatic coming directly in view, it would be easy to go on the common hepatic onto the celiac. I would agree with that.
Okay, if there is no other question, thank you very much. It was a very interesting session. So herewith we conclude this session. Thank you.